Behavioral Health Integration Group. We meet every other Friday from 12 to 1, and this is our second session. It's great to see all of your wonderful faces this afternoon. So let's start with people on the Zoom call, showing their videos. So with introductions, just tell us your name and your organization. Let's start with Lucy first. Go ahead, Lucy.
Hi, can everyone hear me?
Yes.
Okay.
I can hear you.
So my name's Lucy. I'm actually filling in this meeting for my supervisor, Sister Michelle Humke. Our organization is St. Elizabeth Health Center.
Wonderful. Welcome, Lucy.
Thank
Let's
you.
go to Adrian Lindsay.
Sure. Hi. Can you guys hear me okay?
Yes.
Great. I'm Adrian Lindsay. I'm with ASU Center for Applied Behavioral Health Policy and oversee some of our interdisciplinary instruction and evaluation. Thanks for the invite.
Welcome, Adrian.
Thanks.
Let's go to Sarah.
Hi, everybody. Sarah Pedraza, MHC Healthcare.
Wonderful. Welcome, Sarah. Let's go to Lauren.
Hi, everybody. I'm an undergraduate at ASU in an internship with Project ECHO.
Great. Welcome, Lauren. Glad to have you. Let's go to Rafael.
Hey, my name is Rafael Martinez. I'm the Director of Behavioral Health at NOAA, which is an FQHC here in Phoenix, and we have 9 sites.
Wonderful. Welcome, Rafael. Let's go to HRHCTC 0119.
Hi, my name is Brandy Whistler. I'm the Senior Director of Integration and Population Health at Circle the City. We're a healthcare for the homeless organization in Maricopa County, also an FQHC.
Wonderful. And that's Brandy, you said?
Yes, Brandy.
Okay. Welcome, Brandy. Okay, let's see. We don't have anyone on the phone, so we'll skip that and let's go to our ASU hub. Let's start with Christine. Go ahead and introduce yourself.
So she might be having some technical.
Oh, I'm seeing your message right now, Christine. Tech issues. Be at a computer in like 5 minutes. Okay, no problem. Well, I'll introduce Christine. She is part of our core faculty here at ASU and also part of our ECHO Hub. My name is Matt Martin. I'm the director of the Integrated Behavioral Health Hub, and I'm part of the core faculty here at ASU. And to my left is Tyler.
I'm a graduate student at Arizona State University in the College of Health Solutions here. If I can have everyone send me, or all the participants send me their just name and organization and then a good email address and phone number just for attendance purposes, that would be really helpful. And you can send that to the Arizona State co-host chat, and that'd be great. Thank you.
Hi everyone, my name is Josh. I'm also a grad student here at ASU, and then I'm also a part of the ECHO team here. And friendly reminder, when you're ready to talk, in the bottom left corner of your screen, there's the mute button. So when you're ready to talk, please unmute it. And then if you're not talking, if you could just mute it so that there's no other disturbances.
Great, thanks, Josh. So we're missing 2 members of our team here. Adrienne White is out of the country. She's not fleeing the law. She's just out of the country. I think on vacation. And then Leslie Manson is on vacation today, so she's not with us. But they should both be with us at our next meeting, which is going to be April 19th. So I think that's, oh, actually, no, I think we have one more participant. Dr. Sabo?
Hi, it's Dr. Reena Szabo. I'm sorry to jump on late. I'm with Banner MD Anderson and Banner Health. I'm the director of psychology, behavioral medicine, and psycho-oncology.
Wonderful, welcome. Glad to have you here. Okay, I think that's all the introductions. So usually the way that we want to hold the meetings is after introductions, I'm just going to talk a little bit of housekeeping, and then we usually go on to Didactics, and that's where a member of our core team here, our hub, presents on some topic that's related to behavioral health integration. And today is my turn, so I'm going to talk a little bit about measurements of integration. And then our format then continues with, we have a case presentation. And today it will be Breanna, I'm spacing on her last name. Well, Breanna will introduce herself, but we have a case presentation on value-based payments. And so that'll be the last portion of the meeting, and then we will end at 1 o'clock. So let me just go into just some orientation housekeeping. Just a reminder that we're planning to meet every 2 weeks for an hour from 12 to 1. And our main topic is on behavioral health integration. We're focusing on the operational and financial components of integration. We may eventually in the future have a hub that specifically focuses on patient care, where we discuss specific recommendations for working with patients in an integrated care model. But for now, we're focused more on the infrastructure that makes integration care effective and viable. So we're using Zoom, and I think most of you are familiar with Zoom. You just need a link to join. You can download the application to your computer or to your phone, and you can join us through that as well. That is fine. Zoom is easy to use. If you have any trouble, you're welcome to reach out to us. You can use the chat feature to chat directly with Tyler. He has the co-host title. You're also welcome to chat with each other as well. So for those of you not familiar with the ECHO model, the purpose of ECHO is to create knowledge networks, to make knowledge more accessible about a particular topic. It began in the University of New Mexico, and we're using this model to connect with clinics in Arizona to help them in increasing their level of integration for behavioral health services. Okay, so that's the end of the housekeeping. Before we go on to the next part, we have some new participants, so I'm just going to let them introduce themselves. Breanna, let's start with you. If you'll just introduce yourself, say your name and your organization, please. Looks like you're muted right now, Breanna.
Can you hear me now?
There you go.
Perfect. Hi, my name is Breanna Reeser. I am a recent DBH grad, graduated last December, and I work for Care First Health Plans of Arizona, and I am managing their integrated health partnerships and kind of onboarding them with what it means to have an integrated program. So kind of just doing all the first ground level work for integration with the Care First Health Plan.
Wonderful. Welcome, Breanna. Thank you.
Thank you.
Let's continue. More introductions. Let's go to Trevor Davis.
Hi there. I'm Trevor Davis, Chief Clinical Officer at the Guidance Center in Flagstaff, and a proud DBH grad from a couple of years ago now. And yeah, just happy to be a part of this. Thank you.
Welcome. Thanks, Trevor. Let's go to one more introduction, S. Gray 1.
Hi, my name is Shelley Gray. I'm a professor of speech and hearing science at ASU, and I'm lurking on your meeting to find out about ECHO. Thanks.
Wonderful.
Thanks for letting me do that.
You're welcome, Shelley. We're glad to have you here today. Okay, I think those are all the new participants. So we're going to send out a poll before I jump into my presentation. This is through Zoom, so if you will, just go ahead and answer the question, and then I'll just keep going with the presentation. I think Tyler's going to send it out. We'd like to just send out poll questions just to find out more about each of you and your interests and your current just the first integration efforts. Yeah, just the first question.
That should be sent out.
Okay, so as you're reading that, I'll just continue with my presentation. So like I mentioned before, we want to do some kind of didactics for each meeting. Today I'm going to be talking about measuring integration. Yash, you can go ahead and share the slides. So the reason I chose this topic was because I thought it fit really well with Breanna's topic as well, value-based payments. Thank you. Yeah, I thought it fit really well with the topic that she had chosen, and I hope it's going to be helpful to those of you that are maybe just starting to put together a plan of evaluation, of measurement, or even those of you that are already executing your own plan of measurement, that want to have new ideas, look for new ways for collecting data and making sense of that data. So I'm going to talk about the value of measuring your service, review some guiding principles that you'll want to consider when you think of your own plan, give you some ideas for what you can measure and probably should measure, give you some tips for how to begin measuring, and then I'll introduce you to the practice integration profile, which I think some of you will already be familiar with. Yeah, should we go back and do the presentation? Yeah, there you go. Okay. So measuring can be very valuable. It's a way of getting data to identify gaps in your service, and you can use that data to improve your service, to find out which patients you're reaching or not reaching, to find out how many clinicians are engaged in the integrated care model that you've chosen. It's also a nice way of demonstrating value to stakeholders, whether that's to people that are supervising you or to the payers. It's nice to have that data that you can use at any time to show that you're having an impact, that your service is sustainable. You can use your measurement plan for evaluating individual performance. Some of you may be supervisors of behavioral health providers, and you may want to consider the kind of data points that will help to show that your subordinates are performing at an acceptable level. And this is of most interest to me. You can use that data to help advance the science of integration. There's a lot of great work that you're doing. You all have access to a lot of information, a lot of data, and that can be used to help answer research questions that institutions like my own are trying to figure out. In terms of some guiding principles, like I mentioned before, having a strong plan of measurement can help you to use quality improvement principles and to not only improve the quality of your service, but also to maintain it as well. It's really hard to do that if you're not sure what the outcomes are, what the data looks like. Number two, it's important to make your plan of measurement a daily part of your clinic workflow. So this means that is something that you're doing on a regular basis, that you're capturing data points that are part of patient care, whether it's starting all the way from patient identification to when you're following up with patients and monitoring the treatment. If you can make your measurement plan a part of that workflow, then it's going to be part of the norm. It's going to become part of the culture of where you're living, of where you're working. Number three, you cannot measure everything, and in fact, like number four says, not everything should be measured. There's one of the things about the healthcare field is that there is no shortage of data. In fact, the lack of data is not a problem in healthcare. It's really making meaningful use of that data to a point where it's informing decisions about about reform, about the way that workflow is being redesigned. So when you're thinking about your own measurement plan, think about the outcomes, the data points that are most important to you, to your administrators, and to payers. And if there's anything beyond that that you're interested in, just be judicious and pragmatic about whether you want to use it. But you can't collect it.
Can we pause for a second?
1 second.
No, there we go.
Okay. Are you guys able to all see the slide?
Yes.
Okay. Great. Wonderful. Okay. The last guiding principle is that measuring plans change over time. That can be because the standards or requirements of different stakeholders changes, or the target of your service changes as well. So just be aware that that you may need to change your measurement plan every year, every 2 years. Just have that kind of flexibility where you're willing to look at it as a team and change it as needed. Oh, will you click on the slide? There we go. Okay. So what should you measure? So I want to introduce you to one model, which is called the REAIM model. That's R-E-hyphen-A-I-M, REAIM model. And this is a model for measuring the outcomes of a new service. It's been used in a lot of different scenarios. It's not just for integrated care. You can use it for almost any model of care or service. The first letter, R, stands for reach. And this is where you're looking at the penetration of your service. The question is, did the intervention reach the targeted population? It's kind of like hitting a golf ball and finding out if you were able to reach your target with that golf swing. So some examples of how you could answer that question in terms of the reach of your service include things like the number of targeted patients screened, or the number of positive screenings, and the number 3, the number of patients who needed treatment that actually received treatment. If you look at those three examples, you can see that they kind of build on each other. They're interdependent. If you're able to identify the number of patients screened, you can probably also be able to identify the number of those screenings that were positive. And then furthermore, you can identify the number of those patients who needed treatment actually received that treatment. Collecting that kind of data can help you to quantify the reach of your service, how many patients you're impacting. So that's the first part of this REAIM model. The second part looks at effectiveness. The question is, did the intervention change key outcomes? So for example, you could look at symptom reduction. That's a very common metric. Functional improvement. The SF-36 is one measure of functional improvement. Number 3, quality of life. And number 4, care utilization. So a lot of this data is measured, collected in medical settings, and it should already be available to many of you. You may have to introduce new screening tools, like if you're not collecting data on anxiety, you could start to use the GAD-7, or if you're not collecting anything on quality of life or functional improvement, there are a lot of different measures out there. But if it's important to you and your organization for identifying if key health outcomes are changing, then these are the kind of measures that you'll want to consider. Okay, now this one is, at least in my experience, is less common. I don't see a lot of organizations collecting things like the number of same-day referrals or formal referrals. These kind of data points get at the question, of engagement. In other words, how many medical providers or how many providers in general are participating in the service. For me, at the last clinic where I worked, there were integrated care champions that were very much involved in the service. They were referring patients, they believed in integrated care, they had a shared vision, and it felt like they were sharing their patients with the behavioral health providers. But then there were also some medical providers that were not engaged yet, and we were able to measure that by looking at the number of referrals, as well as the number of clinicians who were referring each month. One thing that we did at the clinic was we were able to highlight those clinicians that were referring at a high rate each month, and it was just a nice way to highlight their involvement and to reinforce that. One last thing that you can look at that can help you know how engaged people are in the service is collecting the number of team huddles or meetings. So going back to the REAIM model, the I stands for implementation. The question here is, what is the fidelity to the integration process? In other words, how faithful are clinicians and staff behaving to the model that everyone has agreed to follow? So you could look at the percentage of correct screening procedures. That kind of data is a little hard to collect. You may have to use it, collect it through observation. Another one is the percentage of correct service descriptions. This is commonly used in residency programs where residents are being observed as to how accurate they're describing integrated care. And again, that's observational data. You can also look at the number and type of barriers to integration. What is getting in the way of people following the model that we all agree to follow? And then finally, maintenance. This is the last part of the REAIM model. This is where you're collecting data about the viability of your service, the sustainability. So you can look at total monthly or quarterly reimbursements, the ratio of billable visits to non-billable visits, and the number of referrals for billable visits. I have some colleagues up in Washington that they do a lot of same-day referrals, also known as warm handoffs, but they don't really count those in their monthly reports. They only count referrals for billable visits. And so that's something that you can consider as well. Just a reminder that these slides will be available, and we are recording this, so don't hurt your hand writing notes for all that we're talking about here. Okay, how to begin. For some of you, you love data, you've never met a data point that you didn't like collecting, and so you're very comfortable with this kind of stuff that we're discussing. But for others, you may be very uncomfortable with data, with having a measurement plan, and you're not really sure where to begin. So I want to talk a little bit about that. It's important to first work with the data that you have, and you can use that to identify care gaps. Once you've identified the gaps in your care, and that might include things like maybe you have a large number of patients with diabetes and your integrated care service is not reaching them, or maybe you're not screening for pediatric issues. Whatever the care gap that you identify, the next step is to prioritize, to choose what is the most important quality gap for your organization. And it's very important that you use data to identify that gap and to prioritize it. You can then describe the practice change that needs to take place to address that gap. So this might include a new screening protocol. It might include formal team meetings to discuss patients with high needs, with health complexity. It might require having a case manager who can take on a bigger workload. So once you have identified the change that you need in your organization, you then rally the troops, you put your team together, and you design a plan that will help to measure the impact or the effectiveness of that change. And then you put it into place, and you use your plan for measuring to see if it's effective or not. So again, for some of you, this is the air you breathe. You're very comfortable with measuring and looking at reports and making decisions. For others, especially clinicians like myself, this is something that we've had to learn how to do. Okay, the last thing that I wanted to talk with you about is the PIP, known as the Practice Integration Profile. So this is one measure of integration that's out there. There are several other examples. This is the PIP is a reliable and validated measure, so it has pretty strong evidence supporting its effectiveness. It's freely available. The link is right there. It has 6 domains, things like workflow, patient identification, shared care, and a few others that I can't remember. But it seems to have a pretty wide variety of different activities that are reflective of integrated care practice. Some of you I know are familiar with it. If you're looking for a good, strong measure, this is one that you could consider. And my recommendation, if you decide to use it, is to take it individually, get your own score, and then have your whole team take it, and then meet together as a group to discuss your scores. One thing that I've noticed is one provider or one manager in the same organization can have a different score than what another person took in the same organization. And the reason for that is because the PIP it's all self-reported. You don't pull any data from your health record system. It's all based on what you see happening in your setting. So my recommendation is to use it as an entire team to compare your scores and then talk about what you want to do, what gaps you want to address. That kind of activity would probably take at least an hour and would probably lead to multiple meetings after that. But I think it's a pretty effective tool for improving your integrated care service. And then once you've implemented those changes, you can take the PIP again, maybe at 3, 6, or 12 months down the road. So let me stop right there. I see some questions. If you have any questions, you can put them in the chat or you can raise your hand.
So the scenario and also just a quick definition of like integrated care, so I know where they have nutrition.
Okay. Okay, great. So this is from Raphael. Noah works in the PCBH model. Oh, let me look at it right here. We focus on health behavior changes. The BH consultant will talk to a patient who came to primary care for diabetes, and we'll focus on barriers to health behavior changes. We'll likely see a patient again in 90 days. We have the challenge of what causes a change as many staff talk with the patient.
All right, my question was, we've talked a lot about trying to figure out the effectiveness of this pretty basic primary care behavioral health model where our consultant is available to pretty much talk to any patient at any time. We don't have a schedule. Whoever comes into primary care, you can see 16 of them, you can see 10 of them, depending on the presenting issue. And it is really focused on the health behavior that's getting in the way of improving a lot of chronic illnesses.
Yes. Yeah, so I see your service has a clear focus on changing patient behavior.
Right, we're having a 10 to 15 20-minute discussion using primarily motivational interviewing and focusing on some kind of behavior change, whether it be to take your medication regularly or to exercise more, etc. And often we have a patient come into primary care and they'll end up talking to nutrition integrators in the visit room and the primary care behavioral health.
Yes, yeah. So there are a lot of people that can interact with that patient.
Yeah, so it's hard to isolate where was the change if the patient comes back in 90 days and has an improved A1C.
Yeah. So Raphael, is your question about identifying
how to measure that?
Yeah. So are you interested in identifying what is causing the change, or measuring the outcome of the?
I'm identifying both. I'm interested in figuring out a method on, given that brief description of how we work, how to identify a measure.
Yeah, great question. Before I answer it, does anyone in the group have thoughts for Raphael? His question is about patient behavior change and how do we measure what is causing the change, what is helping to lead to the change, as well as measuring the outcomes of the change. Any thoughts, ideas for him?
This is Breanna. I have a couple thoughts for you.
Okay.
So you mentioned motivational interviewing. You might, if you have the option of kind of breaking it out into a A/B test, do motivational interviewing as compared to another intervention, or if you have a couple of interventions, try doing different interventions in some small sample groups and see if that changes any outcomes. Or if you'd rather do something more comprehensive, maybe just do a survey and ask your patients what they think helped them the most.
Wonderful.
Just to piggyback on what Breanna said, maybe looking at the fidelity to MI at the individual provider level, collecting work samples from them and seeing if you're seeing better outcomes from the providers with the higher fidelity to MI. But I even thought your question was interesting, Raphael, because as you were saying, wanting to kind of isolate what is causing the change, that makes me think it gets away a little bit from the integrated care piece, that maybe there's a segment of all those things together that's sort of creating those positive outcomes you're looking to see.
That was my thought too, and I know that this is kind of radical, especially when we're in such an age of needing to collect data and wanting to prove certain things, but at some point, I think as in the human body, in healthcare too, the whole is greater than the sum of the parts, and making an argument for the necessity of all of these together to really create, to treat us whole human beings. I think there's something to be said about that, and to be said about that philosophy of treatment.
Right, I agree, because when our patients come in, they have a great experience with the front office, with the medical assistant, and then with the primary care, and then behavioral health, and then nutrition. These are all the people that are working towards the improvement of this patient's health.
And can I just say, this sounds wonderful. I mean, your clinic sounds just amazing to be able to do all of that.
Thank you. Yeah, we did a lot of work to get there.
Other thoughts or comments for Raphael? Okay, I would say that I'm also impressed with this clinic, and it reminds me, your question reminds me of some of the research about how good clinicians are at predicting what helps clients or patients to change. And the research shows that they're terrible at predicting it. Oftentimes the patients are changing for, well, maybe not oftentimes, but their change can sometimes happen for reasons that are not always related to the intervention that the clinician was using. So I like the idea of using a survey. That seems to be the least intensive way of getting at this mechanism of change. You may also want to consider what your actual intervention is, and look at ways of, if this is important to you, of creating packages of care or pathways of care. That makes it a little bit easier to measure if certain packages or pathways are leading to particular changes. And the only reason I mention that is because you have a lot of wonderful services and providers where you are. It might be helpful to I guess, organize that in certain ways. Let's keep looking at the chat. There were some other comments or questions. Was that the last one?
Yeah, I think that was it with that.
Okay.
And just a heads up to everyone, we have the video from the last meeting, so if anyone missed anything or wanted to rehash anything that went on, it's just a link to YouTube that has the recording of last or 2 weeks ago, so our first meeting. So feel free to access it via that link provided in the chat.
Thank you, Tyler. Okay. Well, I appreciate Raphael's comments and for that discussion. Adrian asks, do you know of any tools that measure reverse integration? Oh, very interesting question. Reverse, also known as bidirectional. So this is integration where medical providers are working in traditional behavioral health or mental health settings. Let me throw that out to the group. Does anyone know of any measures of reverse or bidirectional integration? Okay, yeah, for me, I actually don't know of any measures as well, Adrian. I'm actually going to look into that. I have some contacts, and I'll see if I can find measures and send it out to the group. That's a great question. Thank you.
Matt, I know that when we did, when I was doing practice transformation full time, we had to work with what was already out there, which wasn't a lot. So it was not a perfect science at all. But I think we can find people who might know the answer to this. That's a really good question.
Yeah.
Yeah, I was asking because
go ahead.
Sorry, and I wasn't sure where the raise hand feature was. I was just trying to. I'm asking because we're working with a couple different organizations that are partnering on a project, and some are more traditional, integration in a medical setting, and the other is more of a reverse integration model. But they were wanting to use the same tool to measure their degrees of integration, and it didn't maybe seem like the best standard to hold the reverse integration site to. So that's why I was just curious if there was something out there like that.
We've done it in the past, but I think your gut is right. It wasn't a good fix. It wasn't a good fix at all. So.
Great question. I'll see if I can find any published measures out there. Thank you. So let's see, we have 20 minutes left. I want to turn the rest of the time over to Breanna. Breanna, if you will, again, just remind us who you are and your institution. And then if you'd like, you can share your slides and just continue with your presentation.
Well, I had difficulty getting on the desktop. I was wondering if you guys have slides to share for me that I could just talk to.
Yep,
Thank you. Perfect. Appreciate it. My name is Breanna Reeser. I am the manager of integrated health initiatives at Care First Health Plan. So I'm coming to speak with you guys a little bit from the payer's perspective, which is probably interesting, and it's something that I've worked in all along. I've worked in health insurance in some capacity for the majority of my career, especially now that I'm working in integrated healthcare. So one of the things that I wanted to talk with you guys about is the opportunity of a value-based arrangement. And I think it's really important to at least know that this is a thing, because behavioral health and integrated health models tend to do quite a bit outside of the services that can be billed for traditional fee-for-service payment models. And this is a good option on how to be able to recoup or get paid for integrated behavioral health in a way that doesn't have to be tied to fee-for-service. So I know that they sent out one of the polls was, if you're currently receiving a value-based payment or not. And so that'd be interesting for me to take a look at. And there's quite a bit of information that I'm going to kind of bulldoze over with you guys here real quickly. But you have my contact information on the last slide. If you have any questions, or if you'd like to talk with me more about this, please feel free to reach out to me for any clarity. So we're going to dive right in if that's okay with you guys.
Breanna, we could share the poll results real quick.
Oh, yeah. Okay, well, that looks pretty good. So 63% have a yes in already receiving value-based payments. That's great. So this might be a little bit of a recap for some people, but you might be interested in knowing kind of what the payer is looking at. And also, I think that it's important, great segue from the last slides, because choosing how to evaluate or how to measure your success of your integrated programming is exactly what we use to create a good value-based arrangement also. So if you are aligning those two efforts, that might help you in the future if you decide to enter into a value-based arrangement, or if you decide to beef up your value-based arrangement, that would be a good way to do it, is to align your current measurement plan or KPI plan with what the payers are looking for, and also what the oversight organizations are looking for. Cool. Okay, next slide. Thank you. So my question for you guys is, how do we best leverage alternative payment models in higher categories of learning action network, or LAN categories, to develop and support integrated practices? Because there is money there that we have available to us to support some of these things. And my question for you is, how do we get there? So do integrated partners currently have value-based arrangements? That's one question. And if you do, are they profitable? Are you getting anything out of those? What are your key performance indicators or measurements that you're already using? What are your pain points, barriers, or challenges to meeting some of those? And what are your successes and best practices? I'm going to end with a question on how do we move forward from just looking at quality to looking at population-specific key performance indicators. And there's a reason for that. Next slide. So what is a value-based arrangement? A value-based arrangement is an additional arrangement on top of, or a layer on top of, an already contracted traditional fee-for-service contract. And it's something that a payer will strategically put in place with their in-network providers that are addressing quality already, or that they think they can have an impact with. So it's my almost full-time job here at Care First to look for strategically aligned partnerships in integrated providers to help grow and promote their progress, because we're seeing that this is having a large impact in our population health, return on investments, and our total cost of care reduction, and some other types of things. And so when we're looking at high needs and high cost members, the integrated health homes really are strategically aligned to be able to benefit from value-based arrangements the most. And it's a bidirectional profitability, because you help the health plan save money on high cost, high needs, but also, most importantly, where we are aligned in this is that we're seeing better outcomes. So we're making people healthier. Some of the alternative payment models that we are traditionally using are things like primary care incentive or performance-based contracts, things like shared risk or shared savings, and then there's other things like capitation or per member per month types of things. Again, these are just types of things that you can get paid for in a practice that have nothing to do with your fee-for-service payment. Next slide. The reason why it's important, besides the fact that it's obviously making a huge impact in population health management, is that it's also required. So Access has requirements from payers, and they are tied to quality measures. And specifically, the reason why it's required for me here is that Care First is brand new to the behavioral health network. You guys probably know this, but as of 10/1, we had a kind of alignment with integrated healthcare, where all providers, all 7 contracted providers from Medicare and Medicaid, now have to be able to offer behavioral health in network. And so we're moving away from the traditional REBA or Regional Behavioral Health Authority model, and we're actually bringing those two network providers together. So there aren't any just behavioral health networks and just physical health networks anymore. Unfortunately, and maybe fortunately in some ways, CareFirst did not align with or absorb a regional behavioral health authority. So we had to build our network from scratch, and that's where I come in. I get to help them understand what it means to have both of those networks and treat people whole patient-centered, not just physical health. That's cool. But Access requires of us that we hit 5 measures. They're HEDIS-based measures, and we have to hit a certain percentage that Access has deemed minimum performance standard on these measures. If we don't hit them in our whole network, so if everyone that we're contracted with in the aggregate doesn't meet this minimum performance network, we have 1% of our entire earnings withheld from us from Access, so that's kind of big. And then there's 2 other things that I'll talk with you guys about is value-based spend, this idea of value-based spend, and then lend categories. The objective that I have for my program, what I want to incorporate and kind of adopt is improving quality and cost of care for complex members with comorbid physical and behavioral health concerns utilizing team-based and collaborative care models. So that's what I bring to the table for CareFirst. And we can go ahead. This is just a visual. So this value-based arrangements alternative payment model idea came about around 2014. And so you can see that Access has required that 5% of all medical spend, so everything that a payer pays out in a year, be through a value-based arrangement starting in contract year 14. And then you can see that as we go forward, that 50% of spend is for contract year 19, and then contract year 20, 60%, and then 70%. So it's a milestone of ours as a payer to create more value-based arrangements with providers that are really causing huge quality outcomes. And so I'm actively looking for partners on this, because it's a part of what we have to do to be compliant with Access as well. And this is something that most payers are struggling to keep up with. So we're having, a little bit more load just from the percentage of spend has to be in value-based arrangements. So this year it's 50% of spend, same as last year, with the caveat that, and then that we move people higher into the Learning Action Network categories that we will cover in a minute here. Go ahead and go forward. So this is a snapshot of the value-based contract baseline. This is 4 out of our 5 Access withhold measures. So these are the things that Access wants to look at. So we have annual dental visit, well child visit, and adolescent well care visit. So those are some of those are pediatric centric. In the performance incentive, you can see that minimum performance standard for annual dental, for example, is at 57%. And so we align our bottom tier of what we pay out to the Access minimum performance standards for Maricopa only. For the North, it's a different story, but this is a Maricopa-based contract, boilerplate. And if you were, let's say, for example, if you were an integrated partner and you had this type of value-based arrangement and at least 60% of all of your membership was able to have a single dental visit within that contract year based on claims, you would receive $10,000 based on your volume of membership, up to $40,000 if you're a higher volume membership partner. So there's a little bit of money in this, especially if you're already doing really well. Those are the 4 withhold measures. The new Access withhold measure is FUH, or follow-up after inpatient hospitalization discharge for mental health issue. And they're looking at 7-day follow-up. So this is a great integrated measure because it's the primary care attribution that it looks at, but it is specifically a follow-up with a behavioral health or mental health provider that checks that box. So that's a collaboration effort, integrated measure for sure that we'll talk about a little bit more. All right, let's move on. Thank you. So current measures that I have in our value-based or integrated behavioral health value-based measures are those first wellness prevention measures that we talked about, plus AAP, which is adult access to preventative services. We also have HbA1c just testing. So as long as you have a diabetic diagnosis and you have a single HbA1c test in a year, we look at that specific measure. And then integrated measures specifically are things like percent of integration. So how many out of your total panel in your integrated office have both a behavioral health and a physical health claim within that contract year. So who's both utilizing both services? That's percent of integration. And then other things like depression remission, satisfaction surveys, and like we've talked about, choosing a model and staying faithful to it. Those are important. In addition to those two, we have utilization things like reduction in emergency room, inpatient, and total cost of care. So those are some things that if you were thinking about creating a measure set that you wanted to look at and start pulling data from, I would maybe take a snapshot of this slide specifically, because this is what seems to be really popular or important to our vendors, our oversight committees, and your payers, and state access specifically. And we can move on to LAN. So this is Learning Action Network, or LAN categories. Basically, this is how to structure alternative payment models or value-based arrangements that have APMs in them. And what we've talked about right now all falls in category 2. So those are things like pay for performance. If you look at C on category 2, bonuses for quality performance. That's basically everything that we've been working towards. And some of it is a little bit higher in category 3 if it has a shared savings in B category 3, any type of shared savings. So my ask of me for my role is, how do we get more integrated partners into any value-based arrangement? But even beyond that, how do we get them into category 3 and category 4 arrangements? So things that are even past just looking at quality measures, but now looking at things like condition-specific population payments. If you're looking at category 4, it's a very population-based payment, and I think that we can do this. This is something that, again, I think that integrated partners are really strategically placed on, because we're already looking at populations. We already know that we're doing the high-cost, high-needs, disease, comorbid condition types of members. And so my question for you guys going forward is, how do we get there? How do we go to at least, value-based arrangements, or really looking at creating strategic partnerships between providers and payers with a population-based membership in mind to really drive home some of these total cost of care reductions and improved quality measures. Go to the next slide here. This is just a snapshot of where we want to go. This is as many integrated behavioral health value-based arrangements in LAN 3 and 4 categories as possible. That's our target ideal state. And that is where I will invite questions before I move on.
Great, thank you, Breanna.
Sure.
So we have 5 minutes. This will definitely be a topic that we'll continue to discuss, but let's use the 5 minutes for any questions. So let's first start with people not here at the hub. Any questions for Breanna? Clarifying questions about what she's asking for.
I know it's a lot to kind of process, so you might take a minute to kind of write it down. And like I said, feel free to catch up with me on another time too, and talk to me about any like cool, creative, integrated kind of ideas that you would have that would fit this model.
Yeah, while people are thinking, let me just see if I can summarize, Breanna, your presentation. There was a lot of good information here. So it sounds like Care First is looking for partners and figuring out ways to move into those categories 3 and 4 of the LAN, the payment categories. It sounds like you're also interested in people, some of the current value-based payment arrangements that people are involved in, and that one thing that you're focusing on is you have an arrangement with Access focused on specific HEDIS measures and a very specific arrangement. And the work that you're doing right now is coming at a good time with all the integration that's happening within the state. It sounds like you're just looking for strategies that can help to move practices from levels 1 and 2 up to 3 and 4, where the focus is on population health management.
That's right. Yeah, and as a point of clarity, every payer has the same requirements from Access. So anybody that you're contracted with is going to have the same haul of getting most of their network up to standard for minimum performance standards, regardless of who you are currently contracted with. And then slide 11, if you want to just end on that, the question is, if you have something that is population specific with a diagnosis focused on high needs and high cost, and has a proof of concept for return on investment and financial feasibility, that's what I want to hear. Like, I guess my question is, send me your pilot projects.
Wonderful. Any last questions for Breanna? Any comments about her presentation? So as people are thinking, I will say that I know that one thing that is vital for getting up to levels 3 and 4 is having strong clinical informatics and having great access to your data, especially for population health. For some clinics that I've worked in, the integrated care model has been broad, where it's focused on all populations, and then other models are focusing on very targeted categories. So it might be the diabetes patients. But anyway, to be able to do that really requires some strong expertise in using your data.
Yeah, and one little small closing caveat is that if you are in network with us and you do enter into a value-based arrangement, we do a lot of that heavy lifting. We'll send you your discharges daily. We'll send you your gaps in care. We'll send you lots of data-driven points that are, from claims perspective, as far as, what marks you're hitting, what you're not hitting, and even work with you on developing some of your metrics, through the actual data that we have as a payer. So that's kind of cool.
Wonderful. That's a great service. Breanna, thank you again for your presentation. We really appreciate it. We have 1 minute left, so we're meeting again in 2 weeks on August 19th. I believe, same time, 12 o'clock. We'll send you the link. If you are interested in doing the next case presentation, if there's some kind of problem or issue that you're wanting to address or improve at your site, let us know, and we would love to give you the time at the next meeting to present your case and then get recommendations from the rest of the group. So I think that's it. So I hope everyone has a great weekend. Thank you for... Oh, is there one more thing?
One more poll.
Oh, I'm sorry. There's one more poll. We wanted to ask you one more thing. So Tyler's going to send out that poll question real quick and just take a minute or a second to answer it.
And then lastly, I know we had some participants join a little later. So if before you log off, if you can just in the chat, just send your name and contact information and organization for attendance purposes, that would be really beneficial for us. So thank you.
Okay. Thanks, everyone. I hope you all have a great weekend. We'll see you in 2 weeks.
Bye, everyone.
Thank you.
Oh, and Adrian, do you want to stay on the line?
Yeah, that'd be great.
Okay. I did not expect that. Okay. Okay. Do they save the polls?
I screenshot them.
You do?
Because I don't know if they
okay.
save them.
Okay, great. All right.
As a recording.
Yeah, you can end the